So we're trying to address the problematic of tinnitus, which is the what people call the ringing in the ears. It's that
Hmm.
buzz that you have. So it's quite frequent, and it can be experienced by a large proportion of the population, and maybe even yourself. You must have experienced that at some point in your life.
Absolutely, I do.
Okay. So and so it could be, after a party, after a concert, after a discotheque. Um, so it can be kind of occasional, but some people experience it all the time.
Hmm.
And they have it constantly. And for other people also, it can be very severe. That means it's impacting on life quality. And that's a smaller part of the population. That's about 2%. And for these
Okay, that's
people, there's
quantified.
yeah. So we talk about tinnitus, and everybody thinks about the being a symptom of something else.
Hmm.
But then for an our group, this is really a major problem. So it dominates over other disorders and so on.
Hmm.
And for these people, there's clearly an unmet clinical need, because there are no effective treatments except for cognitive behavioral therapy, which helps you coping with it, but it doesn't get rid of the buzz.
Hmm.
So there is no recognition of the burden, and there's also poor clinical recognition. So people go and seek help, but there's nothing that can be really done for them.
Hmm.
As a consequence, they're sent back home and told, you have to live with it. Um,
Absolutely, yeah.
so that's one major problem, and also the fact that it's a percept. There's only means of assessing it by subjective assessment. So the person tells you about it. There's no objective measure that can tell you have tinnitus. And because of that, it's also having a consequence on drug development. So pharmaceuticals have feared of going into testing something they cannot really measure.
Hmm.
And then clinical trial testing has been very slow and progressing slowly. And because of that, it has a huge cost to healthcare and to society. And that's why we need more fundamental knowledge about it. And because we need more fundamental knowledge, we need more financing. And that's where, it's been fantastic to have the support from GenderNet. So we started this by having some preliminary data suggesting there were differences between men and women and how distressing tinnitus was. And that's what has been laying the basis of the project Tiger that we're now pursuing with you, which means tinnitus, environment, and genetic risks. So we're trying to understand how genetic background and the environment together can increase the risk for tinnitus. So we hope with this project that we can help policymakers to make like a better definition of tinnitus
Hmm.
itself, recognize it as a neurological disorder and not
Yes.
just only like a mere symptom of another condition, which is the Achille heel of tinnitus now, and that's why sufferers they're impacted dramatically because there isn't enough attention for it.
Yeah.
So we've been, for that purpose, we've been also working a lot with patient organizations like the American Tinnitus Association, the British Tinnitus Association, and we hope that we can transfer our knowledge to them such that they will go, forward it to the policymakers. And I'm very happy I've been joining these associations in order to help patients to being acknowledged with their disorder. Yeah, so Sweden, us representing, by the Karolinska Institute in Stockholm.
Hmm.
As a coordinator, we're working with three other teams. One is in Milano, that's the Institute Mario Negri, and
Hmm.
they're specialists in epidemiology.
Okay.
Another group is in Granada, and they're specialists in genetics. And then a third group is in Bergen University in Norway, which is, experts in statistics. So
Okay.
we had to face the situation where we had really a multidisciplinary approach to
Mm-hmm.
address the problem, and us at Karolinska, we knew more about the phenotype and the disorder, and then we got our efforts with people that had different knowledge in different domains and tried to put everybody together.
Hmm.
Uh, so yeah, that has been a bit of a challenge because not everybody is aware about the methods and the approaches in the other field. But
Yeah.
overall, it's been a fantastic enrichment, and that's how you advance science. Through collaborations and interactions with people that have additional skills you don't have. The way we came to that was thanks. So it was fantastic how everything developed, and we had a first network funding in 2014 by the Cost Action. I don't know if you're
Yeah,
familiar
I
with,
saw that. Yeah, yeah.
and that was named TinNet. So it was a massive network of clinicians around Europe. It's about 300 people that were involved in there. And I was co-chairing the genetics work group with Antonio Lopez Escamas, who's co-recipient in this
Yes,
Tiger.
okay.
And there we started, framing the question: is there a genetic basis for tinnitus? And we've been showing, through twin studies, adoption studies, that there is a familial transmission of
Okay.
tinnitus that is not influenced by environment. And this whole TINNET consortium has led to another EU-funded project, which is called ESIT. That's the European School of Interdisciplinary Tinnitus.
Yeah,
That
okay.
finance, it's a Marie Curie program that helped financing PhD students. So the first funding for the education of future tinnitus researchers.
Okay.
And there we had a basis of PhD students that were working together in teams, and we were addressing some aspects of how tinnitus could impact suicidal behavior,
Mm-hmm.
because it's pretty unclear. There are multiple evidence in isolated cases about people that have committed suicide because of tinnitus, and we didn't get the global picture. Um, and what we started investigating is how tinnitus could influence the risk for suicidal tendencies or suicidal attempts, and that's how we started focusing on that. And while doing this analysis, we were conscious, that there were differences in how sex could impact
Mm-hmm.
psychological burden. For instance, in Sweden, it's quite clear that stress, anxiety, depression is more prevalent in women than in men.
Okay.
And men are more vulnerable for cardiovascular diseases, liver dysfunctions, Alzheimer, and Parkinson's diseases. So that
Okay.
there's a clear trend in how sex can influence that. And so we asked the question, could suicidal attempts being different between men and women? And what we found out is that for those that have severe tinnitus, and we corrected this for multiple influences of suicidal behavior so that we could really pinpoint at the effects of tinnitus itself, there is an increased risk for women, but not in men. And
Okay.
that was a surprise.
Mm-hmm.
Um, there was a surprise, and we found out afterwards that if you assess a group of people and you stratify it by sex, you can see that the stress around tinnitus is much greater in women than in men.
Okay.
So suggesting there could be eventually either a molecular basis for that difference,
Mm-hmm.
because it could lie either in the sex chromosomes or in the whole physiology, or there is an environmental context.
Mm.
So these are things that we wanted to address through
Okay.
the GenderNet funding and try to understand more. What are these differences there? Are there
Mm-mm.
really significant between men and women? And can we kind of start depicting, patterns that clearly distinguish the two? And of
Okay.
course, if in the future that's the case, then that could help, allocating treatments more effectively
Absolutely.
for women than men. And that's also because there are treatments for tinnitus. It's just that they're not effective for everybody. And the
Okay.
question is, whom are they
Is it effective
effective
for?
for?
Yeah.
Yes, yes. So we are, instead of starting with the approach of clinical trials and treatments, we're going backwards with the more
Yeah.
fundamental approach, and we're trying to see what's going on. So maybe for understanding how this works, I should go back into maybe the source of the project. So um, we at Karolinska, we started working 5 years ago in trying to gather more refined, in-depth phenotyping data of tinnitus. And
Okay.
the reason why is that we figured out that there are a lot of cohorts and data already existing and available, but their definition of tinnitus was kind of poor. So if
Mm-hmm.
you look at them, some would ask you, have you ever experienced tinnitus more than 5 minutes in your life? And that person would say yes. But does it mean it has it now, constant? Does it mean it has it severe? You don't know. Others are asking, do you have tinnitus? Say yes, but does it mean you have it occasionally? Is it affecting your life? And so on. So there are multiple aspects here that are missing. And then, of course, you want auditory data to try to see how much this is a confounding effect. And then you want also biomaterial like DNA and plasma to try to identify biomarkers. So with this idea, we started this Swedish project called the Swedish Tinnitus Outreach Project. Outreach because we've tried to go, and reach out for a lot of people. So we started, having flyers and getting participants in, and then that wasn't enough. So we had the chance at Karolinska to have local cohorts, and that's, for instance, Life Gene, that is managed by Nancy Peterson, that was very keen on sharing the information on their participants that had consented for that, and we invited them to join our study so we could make a more in-depth analysis of these people, having controls also, because there are no rich phenotyped database that have control information. The majority of those databases on tinnitus are focusing on patients, but we're lacking the non-tinnitus group. So in that sense, it was a clear advantage, to start like that. So in 4 years, we gathered that material, and then that was, the opportunity with the GenderNet call to try to say, now we have that, we have the plasma, we have the DNA, we have a large population, that's around 6,000 people. So we can start, disentangling that heterogeneity in tinnitus and understand more about it. And the way we're working this is we're having that stop data, and we're sharing with Italy and Mario Negri so they can analyze the epidemiology. We're sharing materials with Granada so they can analyze the sequencing, and we're sharing plasma data with Bergen so they can do the statistics on those biomarkers and try to see. And so the beginning of the project, we've been quite independent, one from each other. So we met for a kickoff meeting, of course, try to set up, how we would be working together. So it took time to do the sequencing. It took time to analyze the plasma. And now we have that data that is under analysis by the different teams. And now we start to have the things that, would allow us to gather together again and have more interactions. Of course, it's been a bit slowed down and hampered by the Corona crisis, and all our opportunities to meet together in different meetings and congresses has been kind of postponed. So it hasn't been as humane as we would have wanted it to be, but we, we're still managing with those interactions and progressing very well. It's fantastic preliminary data that we have there, and we're really looking forward. So it's been really a unique opportunity for us. So at the beginning, it was more Karolinska coordinating with the different entities.
Okay,
But now that we have the majority of the plasma data and the genetics that is under, with preliminary results that are really interesting and significant, we're starting to have Zoom meetings, to have journal clubs.
Okay.
Start to introduce people to the different concepts that they're not familiar with. So epidemiologists, they're not familiar with genetic analysis. The geneticists are not necessarily familiar with the environmental ones. And the statistician is so core into statistics that he needs the biological approach, to be able to have one step back and try to understand what are really the questions we're trying to ask. And the ultimate idea that we have is really to combine all of these expertise together, because when you think about you as a person and your phenotype, it's a combination of the genes you have plus the exposure in your lifetime, and the two together make who you are. So one thing that we want to address in Tiger is, what are the genes, and when they're combined with what kind of exposure in the environment, whether it's stress, it could be noise, it could be gestational problems, whatever. What is it that suddenly makes your risk for getting tinnitus being exacerbated? And if we find that, then that can be fantastic because we can use that for preventive measures.
Yeah.
But also if these are modifiable factors, you can then also try to address that and change your lifestyle so
Okay.
that
Yeah. Yeah.
tinnitus could be reverted, but without interventions in a clinical context in a way. So that's kind of what we're going to. Since the work since the work we had done on the suicidal risks, um, we used the stop data to try to identify those comorbidities that are the most strongly associated with tinnitus. And the ones we found out was temporal mandibular joint, so the complaints in the jaw and the clenching. So it could be related with somatosensory impacts on tinnitus. So all the nerves that are around the jaw, they go and fuse with some layers in the auditory pathway where they could exacerbate tinnitus. So people could maybe cringe at night or have a displacement in their jaw that would trigger different inflammation potentially over the joint and this region here that could influence on tinnitus. That's one thing. The other aspect is also headaches. We found strong associations. And the last one, which we just recently published, is hyperacusis, so the sensitivity to sound. And it was clearly known from the past that people that have tinnitus also have sensitivity to sound, but how much that relationship, how strong it is, and what's the quantifiable value of that association was missing, because most of data didn't contain control data. So we were able to score that, and it's impressively strong, that relationship. So now that we have that, as key elements, we see that this is quite important for future studies, because if you want to address, the genetics of tinnitus or their biomarkers, you need to consider hypersensitivity to sound seriously, because it's a very important confounder. Now, the problem is, we've been also working on registry data, for instance. So medical data in Sweden, it's quite common to ask the government for access for this information.
And what about the rest of the countries?
The other countries, not that easily. So you potentially could, but it's not as easy to access that. You go locally eventually to a hospital and access that information, but at the scale of the nation, that's very difficult. So the Scandinavian systems are in with this kind of mentality, and that's why it's favorable. But the temporomandibular joint is not coded, so you have ICD codes that can classify criteria according to the WHO into a disorder that's been listed. So there are codes for TMJ disorders, but they're not used in Sweden. So it doesn't make this usable. Same for hyperacusis. It's not a condition that's recognized enough. Also,
to exist,
measure, and it's not existing. So at least what we see now, is that the key factors that accompany tinnitus, they're underestimated in the clinical system, and that's where our first implementation should happen to improve the care, not only of those that have tinnitus, but temporomandibular joint problems are frequent, and dentists are addressing this, but they're not directly coded into the whole system of the registries. So that's one part. And we recently also found out 5 blood biomarkers using the STOP data. So we did a case control study with 500 cases and controls matched for sex and age. And the analysis that we've done was using like the OLINK platform, which is an assay that is able to assess about 96 different proteins and in the circulation for one sample. So with 2 microliters of plasma, you can check the level of 96 proteins. So with that screen, it was fantastic. So with the money from Tiger, we were able to perform this first analysis, and we found 5 proteins very close to significance in our tinnitus people. And in fact, we used that data to apply for additional funding to replicate that observation in an independent cohort And we just got the news. We obtained funding from the British Tinnitus Association.
Congratulations then.
Yeah. So, yeah, and that's fantastic because if we can show in another independent group of people that the biomarkers we have are associated with tinnitus, then it establishes the first plasma biomarkers as reliable proteins that we can assess in a clinical setting. So that's very good. And then on the side of our partners in Spain, they've done a study where they first assessed people with Meniere disease. Maybe you're familiar with Meniere disease.
Sorry, the?
Meniere.
Meniere, okay, yeah, yeah.
So it's a combination of balance problems, hearing loss, and also tinnitus, and it can vary in how the three combine with each other.
Okay.
But Granada works a lot with Meniere's. So they designed a study where they had people with Meniere's with or without tinnitus, but severe tinnitus. So there they managed to find some variants associated with tinnitus, and we used STOP in Sweden to validate what they have found.
Okay.
And we identified two genes that are associated with tinnitus, and now we're trying to see where they're expressed. Is it in brain? Is it in the cochlea? Can we show, with more evidence that these are really tinnitus biomarkers in a way, rather than some other confounding effect? So now we're on the type of validation stage in this aspect.